couple of quick questions at the start as we get ready for the show. Sorry for the glitches, but we're just getting everything ready. It looks like people are beginning to log on. Should be ready soon. Yeah, there we go. People are starting to join. Welcome, Instagram. It's taken a little bit of time to get this organized, so my apologies, but people are joining us now. So Instagram and Facebook and YouTube and Twitter are all the services that we use, and it can be a little bit of a glitchy system to get it all working, but it looks like everybody's joining on now, so we've got a good show ready to go. Okay, so as everybody joins on, I'm going to get started with a bit of a discussion, and I'll give the background history before we get into the nitty-gritty. So the reason I wanted to pick this week's topic is because we, like everybody else, do have patients where it can be difficult or challenging to get their infertility to be resolved. And in some of those instances, we turn to more advanced therapies like IVF. And even sometimes with IVF, it can be challenging. Sometimes we have difficulties getting patients to be able to produce the right number of eggs and then produce the right embryos, high quality embryos. But even when all of that is in place, even when you test your embryos to make sure they're genetically normal, the estimate is that only about half of the embryos will actually implant and stick, even when they're euploid, meaning we know that they're genetically normal. So the question is, why is that the case? And why is it that sometimes it does not work? And the answer is, we don't always know. In some instances, it might be something wrong with the structure of the uterus. It might be something wrong with the lining. It could be something wrong with the patient. And when we turn to something wrong with the patient, we start wondering if it's a problem with the immune system. So we do know that the immune system needs to be active during implantation. So there are three major components to your immune system that are involved with your fertility. So one are the T helper cells. And for those of you that are old enough to recall or have learned it in biology, the HIV days, T helper cells are some of the cells that are attacked by HIV, the virus. And so T helper cells are actually very, very important in your implantation. And there's a T helper cell 1 and a T helper cell 2, TH1 and TH2. And the various ratios of those two can really significantly impact your fertility, your risks of recurrent pregnancy loss, your risks of implantation failure or recurrent implantation failure. So that's a big, big critical element of what we deal with. The second are little molecules called cytokines, which are immune signaling molecules. And those molecules are essentially responsible for making sure that the cytokines and the cells are receiving the right signals, that your immune system is receiving the right signals, and that everything is functioning smoothly from the standpoint of which cells are supposed to be called in to function, which cells are not supposed to be there, how aggressive are they supposed to be, should they be in attack mode or assist mode, are they healing something, are they curing something, and so on. And then there's a whole relative field of science on something called natural killer cells, which do exactly what they are called. They actually kill things. And these are the ones that are supposed to attack, but they are actually supposed to be there when an embryo implants. No one knows exactly why or what their function is, but we do know that they're critical to the success that we need in order to achieve a pregnancy. So I have connected myself with two physicians in the Toronto area who sort of subspecialize in what we call immune reproduction or reproductive immunology. And they've done some extra training and some extra sort of clinical work on whether or not there are immune modulations or immune treatments that we can use to improve your chances of success when you've had these recurrent pregnancy losses or recurrent implantation failures. And so I've even started sending some of our consults to them. We even have a patient I communicated with recently from the US who is reaching out to them as well. And so I thought, we should kind of delve into this a little bit to see how much of a difference it makes. And I'm going to warn you in advance that there are not a lot of great studies on this, and this is all very poorly understood because it is very difficult to kind of connect the dots between the measurements we get in the lab and what we see in terms of lab values for this ratio or this level of a cytokine, or that amount of natural killer cells, and what their actual function is in the lining, in the body, in the bloodstream. So the first problem we run into is we can't always tell if the function of what we're dealing with is the same as the quantitative aspect, as close to the measurement as we can get. So with that in mind, people have been studying these things for years. So they've looked at things like the T helper cell ratios. They have looked at things like whether or not the cytokines make a difference, and they have looked at the natural killer cells. So I want to kind of review that part of it with you, and then we'll go over the treatments. So helper T cells are really important. We know that the T helper 2 cell is really important in normal pregnancies, and that you want a predominant T helper 2 ratio with less T helper 1 cells. Patients that have higher ratios of T helper 1 do tend to have recurrent pregnancy loss or recurrent implantation failures, whereas those who have a Th2 dominant status tend to have normal pregnancies without any complications or problems. So we know that that has been implicated, and there are numerous studies that have demonstrated that. As well, the cytokines that I mentioned earlier, those little signaling molecules, they're actually produced by the T helper cells. So when you have the right ratio, you get higher levels of cytokines like interleukin 4, 6, and 10. And those are the beneficial ones that you want, whereas you can get abnormal ones like interleukin 2 or interferon gamma and tumor necrosis factor alpha. And all of those are sort of adversely impacting your pregnancy chances or increasing your risks of failure and recurrent pregnancy loss. So as a result of all that, there is good evidence for these T helper cells and their subsequent chemical signaling products, the cytokines, being involved with your fertility and your success in a normal pregnancy versus recurrent pregnancy loss or recurrent implantation failure. Natural killer cells are really important. So in your blood, they account for about 15% of the lymphocytes, the white blood cells that are in there. But we know that in the uterus, some of them can act, or at least we think that some of them can act too aggressively and attack the embryo or attack the endometrium and make it an unfavorable or inhospitable environment for the embryo to implant in. And you'll frequently see CD56, which is a specific type of natural killer cell in the uterus. And when you have these CD56 or CD57 cells, these can have altered expressions in the uterus, and when you have that altered expression in the uterus, it can again impact your fertility positively or negatively. So in order to modulate these T helper cells, the cytokines, and the natural killer cells, people have tried everything you can possibly imagine. So I'm going to go through some of the bigger, more common ones, and we're going to discuss those to see if the therapy actually makes a difference. So the big one is intravenous immune globulin. So these are little proteins that float around in your bloodstream, and they basically are non-specific binding molecules which can bind to other things and kind of slow down the immune system or reduce the attack capability of the immune system. And it's used in multiple different conditions. We see it sometimes used in platelet disorders. We'll see it used sometimes in patients that have various autoimmune conditions. A lot of blood problems will use intravenous immune globulin. So there have been a lot of studies done on IVIG. In the early days, multiple studies showed a significant benefit to using it. So for example, they have a study here, which was a retrospective study, and they gave patients IVIG, the intravenous immune globulin, 3 times a week in the first trimester, and then 4 times a week up to 35 or 36 weeks. And the live birth rates increased from 17.9%, which is obviously very low, all the way up to 80% in the recurrent implantation failure group and from 30.8% in the recurrent pregnancy loss group to 96.3%. So in that one study, it did show this huge benefit. Obviously, everybody jumped on board, started doing the testing. Problem is, we're not actually sure that it works, because when they've done larger trials, while some have showed a benefit, including one meta-analysis that looked up at over 2,400 patients, 2,415 patients to be exact, they showed the live birth rate was 49.8% in the treatment group versus just 31.6% in the control group. But when they looked at other meta-analyses, and there's a Cochrane database that we frequently turn to look at really rigorously well-done meta-analyses, that study done in 2014, so it's going back a ways now, did not show a benefit. Sum total, we are due for a new review to see if this stuff actually works. The people that believe in it just staunchly believe in it and swear by it and say that it works. The people that don't believe in it swear that it doesn't work because they've looked at the older studies. So we don't have really good data for the IVIG right now. The problem with IVIG in Canada is that it is controlled by Canadian Blood Services, so we can't even get it unless we purchase it from the US, where it is astronomically expensive. However, I have found out recently through some work we've been doing with my colleagues in Toronto that we may be able to get a subcutaneously injected version of this very, very inexpensively, possibly even for free, which is what we're working on right now. And if that's the case, that would be awesome, because we do know that it does not appear to have any negative effects. And if we can get it for free and use it for some of our patients, that would be amazing. And so hopefully that's a possibility. Katie and my other friend, who I won't name because I don't want you guys to be identified, I am talking to you. So hopefully we can use it for you guys if possible. The next obvious one is steroids. Do steroids work? So many of you who have worked with us will know that we do try steroids when we have patients with recurrent pregnancy loss, but we normally use it in conjunction with other elements. So aspirin, heparin, and we put them all together. So the interesting thing is that when you use steroids by themselves, so you're just giving the patient steroids, it actually does not appear to have any benefit. But if you use steroids with aspirin and heparin together, that actually seems to have an incredibly potent effect. So in another study, they showed that in 52 of 74 patients, so that's 70%, they achieved a live pregnancy, and these are all people with recurrent implantation failures, whereas only 9%, 7 of 76, succeeded when they did not get the heparin and the steroids. It is doing this weird flickering thing.
What's on there?
Is it live doing that too? Maybe check and see. And then they did another one, a prospective randomized placebo-controlled trial. And in that one, they showed that in the combination group, 85% were able to conceive. In the heparin group alone, it was 46 out of 57, which is 80.7%. And it was only 48% in the no treatment group. So it does look like using the steroids with aspirin and heparin, or at least heparin alone, can definitely make a substantial difference and a big improvement in your success rates. So I think that is something that is important for us to look at. Why does it work? We actually don't know, and that's part of the problem. You guys want answers, and we want to be able to give them to you, but unfortunately we can't always answer because we don't always know how the mechanism is functioning, but we do know that it appears to work clinically, and I think that's really important. The next area of important medication
alone
is treatment with the strong immune modulators. So things like Humira, which has this complicated name of adalimumab. And these are things we use in people, for example, with Crohn's disease, or sometimes other agents we use in patients who have organ transplants and so on. So in all of those people, we definitely use some of these stronger agents which can really impact the immune system. And most of them work through the tumor necrosis factor alpha blockage, which settles down the immune reactivity and the immune function. So there is a study that I've looked at from years and years ago where they combined IVIG treatment, the intravenous immune globulin we were talking about a moment ago, with Humira in patients that had had 6 previous recurrent failures. And in that group, they actually demonstrated that they went from like 0% with all these patients that had had multiple failures all the way up to an 80% success rate in the limited group of patients that they, sort of categorized as a subgroup. Those numbers are huge, and to be honest, nobody's been able to duplicate those, so it seems a little unreasonable, but there are studies that have demonstrated that using Humira can improve your recurrent implantation failure patients and your recurrent pregnancy loss patients. Again, the problem, it requires multiple doses and it is insanely, absurdly expensive. So if you have coverage for it, that's amazing, but then you need a reason for it, and normally they won't cover it for fertility patients. So it can be very, very costly to engage in this stuff. The last one is a drug called tacrolimus. So tacrolimus is a drug that we use when we're doing solid organ transplants, heart, kidney, lungs, so on. And when they used that, they also showed an enormous improvement in success rates for fertility patients who had recurrent implantation failures. Again, it seems to modulate things through the cytokines, the tumor necrosis factor, the interleukins. And what they showed was when they gave this to patients who had recurrent pregnancy loss or the recurrent implantation failures, they had a live birth rate. So again, that's the holy grail for us, the live births, of 64% versus 0. And, that's just a unbelievably shocking number. So there is some data that suggests that tacrolimus may be helpful. Interestingly, when you talk to or discuss this with other experts or read the studies of other experts, they definitely will argue that none of this is true and that the studies have not been done well enough. So I think the data still needs to be solidified, but I think there is enough data to suggest, number one, that your immune system definitely plays a very significant role. That 2, there can be alterations in your immune system which will negatively impact your success. And 3, and perhaps most importantly, that there may be ways to modulate that. And that modulation would be things like your IVIG, the steroids, the heparins, because they're very good immune modulators, and anti-inflammatories, and as well to maybe try some of these other ones like Humira or the tacrolimus. And we'll probably do a little bit more research on the tacrolimus to see if that's a reasonable option for our patients. Humira is great, but it's unattainable. It's just so expensive. I'm going to look into seeing how much tacrolimus is and whether or not that's a reasonable option for you guys. So fact or fiction was, do immune therapies work or improve your fertility success rates? Well, when you've had recurrent pregnancy loss or you've had recurrent implantation failure, it does appear to be a successful technique. So yes, there's the hammer for you, Derek. It does appear to improve your success rates. And so we do think that it's worth at least looking into it. Again, unfortunately, the testing can be astronomically expensive. The treatments can be very expensive, but we're trying to find ways to make it so that you don't have to pay anything. For example, with this new IVIG therapy, steroids are quite inexpensive, and many of you will have coverage for the heparin. So frequently, we'll even treat you without testing you because there really tends to be very, very few side effects to most of these meds and treatments, but the benefits may be there, and so it's worthwhile doing. If you do want the testing, we're certainly happy to provide it. And we have arrangements with labs around the world to do that. It is very, very expensive. You're looking minimum somewhere between $1,500 to $2,500 US for that testing. So for the patients that need to know, I think that's very reasonable. But for those that don't need to know, it's actually cheaper to treat you than it is to test you. And that's something we frequently discuss. Okay, so fact or fiction is done. I went on too long, but we were having some technical difficulties at the start there. So I am more than happy to take your questions. It looks like we have some on Insta. And there were some pre-questions before too, right?
Millions of pre-questions.
Was there millions of pre-questions? Okay. That might be a handful.
But let me just reload it if you have questions.
Up here?
Yeah.
Why do you think it's not working?
Yeah. Just do this question, I'll reload it.
But then we lose everybody. Or is it off? Okay.
Yeah.
Okay. So is it normal to have lower back pain and major pressure in your vagina at only 11 weeks pregnant? Oh yeah, we got Facebook questions up the wazoo. Fertility and nutrition, what do I suggest? Okay, so nutrition and fertility is really important. We've done fact or fiction on that before. So if you go to our YouTube channel, Victory Reproductive Care, we have some stuff on nutrition and we have lots of stuff on vitamins. We also have a couple of sessions where Dr. Jennifer Strong, our naturopathic doctor, has been on with us, and she can address those questions for you. We'll probably try and bring her on again when two people can sit close to one another without COVID concerns. So bottom line is, yes, your nutrition's important. You want relatively low sugar because sugar is very pro-inflammatory. You want relatively low cholesterol, high protein diet, lots of antioxidants, so fruits, vegetables. You don't want too many calories, and then you want loads of vitamins. So vitamin D, coenzyme Q10, C, D, E, those are all really important vitamins. You want to try and get some fish oils in there, and then of course your standard prenatal vitamin with iron and folic acid and so on. So that kind of nutrition is really important. Avoiding meats is probably going to be beneficial. I'm a pescatarian now. I rarely eat any meat. Once in a while I have cheated, so I hope the Pescatarian Society doesn't come after me or anything like that. But you definitely want some good nutrition. That's super important for you. Okay, I think we're back up and running, so you have to tell me if it falls apart.
How many months on average does it take most couples of trying before they're able to conceive?
So I'm not sure if everybody's hearing these questions from Tarek, but so it was what's the average, just pull up the chair. What are the average number of months that it takes to conceive? So there's good data for that. So 60% of couples will conceive within 6 months. 80% of couples will conceive within about a year, and 90% of couples will conceive within 2 years. So basically, once you've passed the 1 year mark, we know that only 10% of you are truly infertile, or at least infertile past 2 years, but we start investigating because we want to know what that 10% is so we can start helping them before time passes.
Okay. Got a lot of questions already. What are some natural ways to treat endometriosis?
Okay, so no one for sure has been able to prove that any of the natural treatments for endometriosis work. So if you go on, again, our YouTube page, you'll find a whole 35 or 37-minute talk on endometriosis, and I do address the natural therapies. There is some minimal evidence that NAC and acetylcysteine can be beneficial. There's some minimal evidence that turmeric might be helpful. A lot of the other stuff that people talk about is not helpful. So you go online and you look up these nutrition people that are talking about all these magical natural therapies that work. But when you pull them up in PubMed, which is the scientific sort of literature resource we use, when we're looking up things, like what I do every time I'm looking up a study for you guys, I'm getting it all from PubMed. So I go there and I search, and then I pull the studies off of there. So, a lot of these natural therapies, there is not a shred of evidence that it works clinically. There may be some in vitro studies, which means they saw what it did in cell culture, but there's very, very little data that it actually works in patients. So there is no known natural therapy. We do tell patients to use the NAC because it's harmless. We definitely tell patients to stay on their vitamins. And yes, it's probably beneficial to be on turmeric, but we don't know for sure, so hard to answer that question for sure. I got one here. How long between transfers after a C-section? So ideally after a C-section, you're breastfeeding for a minimum of 6 months. Once you're past the 6 months, you're good to go. It's not a problem. Alana, you're welcome. If you are back up and running, do you presume the crying banks, you meant cryo banks, will begin shipping as well? We don't know, but I'm in touch with them this week, so hopefully I'm getting an answer because we expect to be back up and running soon. You want to ask one?
Sure. Yeah. Unexplained infertility. What are some causes I should explore?
I saw that question earlier. So by definition, unexplained infertility means we don't know the cause. So it's kind of hard to explore. However, the main one you want to rule out is a problem with endometriosis and then pelvic pathology. So typically that requires a surgical approach to things if you want an actual diagnosis, not just treatment. There are treatments you can take for unexplained infertility that don't require surgery, but if you want to know what your diagnosis is, you have to really undergo the surgery. The other one we recommend now is doing sperm DNA fragmentation testing, and that frequently can help us know if there's a problem with the sperm component of things that won't necessarily show up in the semen analysis. So we do quite a bit of that now. And it's been really valuable because we are finding that many of the guys have compromise, and there are things you can do naturally to improve their sperm before you're doing your fertility treatment or jumping into any kind of fertility treatment to help. So it doesn't necessarily mean that because you have a high sperm DNA fragmentation, you immediately need to jump into anything. Sometimes you get the opportunity to modify things naturally and improve your chances. Fire away.
Is it a myth that flying during first trimester causes miscarriage?
Yes, it is a myth that flying during first trimester causes miscarriage. You can fly. We don't recommend you go in the first trimester because the air pressure changes may not be beneficial, but literally millions of people before COVID were flying around pregnant. Most of them probably didn't even know it. And the miscarriage rate does not appear to be any higher. Theoretically, because you're in a pressurized cabin, it's not ideal for the oxygen and carbon dioxide exchanges that go on in the womb, but it's probably relatively safe. Certainly if you're going a short trip, you're not going way up high, that's probably very safe. If you're getting on a 747 and you're crossing from Toronto to Sydney, Australia, sure, that's probably going to place you at a bit more risk. I remember reading about this years ago, and they said that the amount of gamma radiation you're getting from being closer to the sun is more of a risk than the air pressure changes. So there's probably risks from being up there, but it's probably very, very minimal. Let me do one from here. I meant to ask the other day in my question on Instagram, what is the benefit of starting progesterone after ovulation? I'm still trying to discuss with my RE as I am set to ovulate in a few days here in the US, if I can get to them at all. Oh, right. So hello again. I remember chatting with you via Instagram. So yeah, the problem with every study done on progesterone, in my opinion, is that they're all done with the progesterone starting too late. So most studies on progesterone actually do not demonstrate a benefit. But all of us that do fertility treatment start patients very early, and we know that it works because we see it clinically. So once you're trying to establish the pregnancy, the most important part is that critical first few days when the embryo is attaching and implanting and forming its connection to the uterus. That's when the progesterone is most important, and then you want the uterus to stay in the same sort of level state that it's in once it's achieved that state. So you don't want to manipulate the progesterone later on. So it doesn't make sense to me to start the progesterone later. It's always made sense to me to start the progesterone early, and literally no studies have done that. So it's critical that you start it right away because you want the progesterone there to support the implantation of the embryo. Progesterone is necessary for the endometrium to luteinize in order for an embryo to implant. And so that's why you want it there to deliver that. And also, do not take it orally. Loads of people are told to take progesterone orally. When you take progesterone orally, it has 10% of the bioavailability of vaginal. So we only give it to patients orally when they can't tolerate it vaginally or when they can't take the shots. And we're using the progesterone oral and vaginal together. Someone's asking about, does this apply to type 1 diabetics? Joanne, I'm assuming you're asking about the immune therapy. Type 1 diabetics are a whole other issue. The most important thing you can do from an immune standpoint is control your sugars very, very, very well. So when you're a type 1 diabetic or an insulin dependent diabetic, it is critical that your sugar control be exceptionally good, that your hemoglobin A1C be very, very low, ideally under 6, which is very tough to do, but necessary in order to achieve a good success rate. We don't tend to mess with the immune systems of diabetics because you are slightly higher risk of contracting infections, and modifying your immune system can actually increase your risk of getting infections. So we need to be a little more delicate there. And then on top of that, giving a diabetic steroids will shoot their sugars through the roof. So not all of the treatments can be used in a diabetic. How long after my last shot of Lupron should I expect my period? Usually if you've taken the 3-month Lupron shot, around the 4th month from the time you actually took the shot, you should be getting your period back.
Why are you so amazing?
How can you read that,
I
man?
thought that'd be good.
We're going to ignore that last question. Next.
Any ideas when IUIs is starting up again?
Yeah, so we are waiting for the CFAS, the Canadian Fertility and Andrology Society, to publish the document I was part of creating, stating what the guidelines are for reopening. And then the Ontario fertility centers will all have a conference call and we will determine when we're going to reopen. We're probably planning to start fairly soon. So again, I don't want to pin down a time, but start calling in and we're going to start getting everybody lined up. No guarantees, but I think the province is reopening. The world is beginning to reopen now. New Zealand this morning reported no further cases in the entire country. So I think we're headed in the right direction. Yay. Finally, we're pulling out of this. And thank you to all of you who did your part to make it safer for everyone out there. And thank you to the first responders and the frontline workers for everything you guys have done. The nurses in particular, you guys are just awe-inspiring and amazing. So thank you for everything you've done for all of us. I don't think we can ever repay you, but you're forever going to be in our hearts and our minds and in our prayers.
Do we have a deadline as to when we have to decide what to do with our embryos?
If you're speaking about Nahal embryos, no, there's no deadline. You can leave them there indefinitely. And we very much want you to feel extremely comfortable with whatever decision you are choosing to make. There is zero pressure from us. If you want to keep them at Nahal, by all means, keep them at Nahal. If you want to ship them to us in Windsor or have them transferred to Create, by all means, we can arrange that for you as well. I don't want anybody to feel awkward, pressured, uncomfortable. It has to be something you want to do, and you got to be aware of the risks and benefits of each option. Unfortunately, I can't have anything to do with them when they go to Nahal, but Dr. Mazidi is there, and they will take care of you as best as they can. So, for sure, if you want to keep your stuff there, by all means, keep them there. And you do not have to decide if you're not doing anything with them. It's only if you actually want something done with them that you have to make that decision. Let me chat here. Are you currently testing now? Yes, we are testing. We've been testing all along. My first FET failed. My second was a success with prednisone, heparin, intralipids, etc. Would any subsequent FETs be on the same protocol? Hi, Lorena. The baby's good. Yes. I'm a big fan of if it ain't broke, don't fix it. So if we've done something that works, I don't like to mess with it, and we just do the same thing again. And I think that makes a lot of sense. If we've done something to you that worked one time, it probably makes sense to repeat it the second time. Some people believe that the pregnancy itself is what we call salutary, meaning it has a beneficial fertility impact for you. And that may well be very, very true. So if you have enough embryos and you want to try without any of that, that's totally reasonable. But most of the time we try and repeat things and do it the same way again. Let me take one more. How long do you recommend waiting between giving birth and doing an egg retrieval? Breastfeeding until done, and then we can do your egg retrieval. Yeah, go ahead.
What kind of supplements, medication should females take when trying to conceive naturally?
So same things I talked about earlier. So just real quick, very healthy diet, low in carbs, low in fat, high in protein, lots of fruits and vegetables, as many antioxidants as you can get, which are basically vitamins, coenzyme Q10, the fish oils, all of that stuff is the nutritional component. Pineapple, we looked that up. That actually does seem to be helpful. Melatonin, there are some natural substances. If you have PCO, things like inositol, NAC, all of these can be helpful.
Thoughts on Tdap shot during pregnancy after repeated losses?
So Tdap is the pertussis vaccine, and so there's a big push to do it because babies that get pertussis when they're very early can end up in the hospital for months. My problem with it is that I looked it up, and you need to treat 999,987 babies to extra to kind of rescue the 13 that are going to get into trouble. So is it beneficial to treat 1 million people to keep 13 babies out of the hospital for a couple of months? Probably, because those moms and dads are going crazy and worried and anxious, and that's a huge drain on our healthcare system. And the vaccine is simple and effective and has no risks. Um, but it is a huge number to treat for 13 babies that end up being okay for the most part. They just are in the hospital for a while. So um, I'm not 100% convinced, but I do follow my society's guidelines and we do recommend you use it.
I'm overweight, but no health issues. Can I try for a baby or do I have to lose weight?
So go to our website, www.dr for drvictory.com. There's a resources tab, and in that resources tab, one of the sections is on obesity and infertility. And if you scroll down to the bottom on the left side, there's a long download, and that doesn't take a long time. It's just a lot of information. And there's a lot of great info for you there to look at. We tend to be as respectful as possible of our patients that are struggling with weight as part of their infertility. And the short answer is it has a very significant impact on fertility, on implantation failure, on recurrent pregnancy loss, on miscarriage. I mean, pretty much everything. High blood pressure, diabetes, even the loss of a baby after it's born is higher when mom has weight as a factor. So it depends on where your weight is at, and there are categories, and it's all specified there. So just to respect everybody, I strongly advise you go to the website. If you have individual questions, give us a call. We'll make an appointment and we'll chat about it. Let me take one from here. I have unexplained infertility. It's been 4 years. We're waiting to hear if we're still on your funded list for IVF. What do we do in the meantime? I am very sorry. We have applied to the government for funding for our Windsor program. We are waiting to hear. COVID threw everything for a loop. When we recently talked to them about the application, the response was, "Are you kidding?" They're just not interested in talking about it right now. So I don't know yet what's going on with funding. We have been granted some funding from our colleagues in Toronto at Create, but it is minimal and it will take a long time. Feel free to reach out to our nurse, Sarah, and she can probably tell you where you are on the list. But unfortunately, we're at the mercy of the government for this, and I don't know what they're going to do. In the meantime, if you're eligible for IUI, try IUI and do all the natural things we've been talking about. Make sure you're having frequent intercourse every 2 days, track your cycle, stay healthy, all of those things. We had 7 failed IUIs with meds and shots. Yeah, so I mean, again, that's probably, and that's the same patient that was just asking. That's probably enough IUIs, especially with meds and shots. Surgery would be an option if you haven't had the surgery yet. And if you have, then IVF is the way to go. And unfortunately, sometimes we have to engage in doing private IVF because we can't get you funding. Go ahead.
Is there any real way to know if the problem is with fertilization or implementation?
Implantation,
yeah.
Yeah, I mean, if you're doing IVF and you try natural IVF or conventional IVF where we just drop the sperm and the egg together, which I don't recommend, by the way, but if you do that, you'll see if it's a fertilization problem because you won't get good fertilization. However, we typically recommend you do ICSI where you inject the sperm into the egg because it increases the fertilization.
If you had a previous miscarriage, would you recommend taking progesterone during pregnancy?
Not for just one miscarriage, but for multiple miscarriages, yes. So if you've had 2 or more, we start investigating, but not for just one miscarriage. You don't need it for just one. Let me answer this one. I'm concerned that getting pregnant now will leave me giving birth around the 2nd or 3rd wave of COVID, placing my baby, my family, and myself at a higher risk. Is this a fair concern? Okay, so as far as we know, nobody knows whether or not there will be a 2nd or 3rd wave of COVID. Hopefully not. So ideally, we're going to avoid that as much as possible. To give you some kind of idea, in the US, they are testing about 2% of the population per month in each state right now. We should be able to get a sense of how many people have had it who actually didn't have the symptoms. And that's going to be really important because there are probably loads and loads of people out there who have been exposed, had it, and didn't even know that they got it, or had a mild cold or something like that. So in terms of babies, babies actually do exceptionally well. Young women who are in reproductive ages do exceptionally well, and so do most guys. It's older men who have high blood pressure, heart disease, diabetes, other health conditions, which are not doing well, and women as well, but there's a much higher ratio of men dying from it than women. You guys tend to be stronger than us, so that probably is a big part of it. Okay. So would you recommend taking progesterone after ovulation? If yes, how much and how long? So if you're taking Prometrium, 200 milligrams 3 times a day until 12 weeks, and then cut it down to 100 milligrams 3 times a day and do that till 36 weeks. What's the average cost for IUI? Meds not included. $350 for normal and $450 if we're doing the new technique where we can reduce the amount of sperm DNA fragmentation. Go ahead.
Is aspirin and Chinese herbs okay during stims? Acupuncturist recommended.
Aspirin is definitely recommended. We have a whole Factor Fiction on that. So again, go to YouTube, Victory Reproductive Care, and check that out on our channel. Make sure you like, share, and comment. That helps us out in terms of what to do next. And subscribe to the YouTube channel. That's very helpful for us in growing it as well. Yep. So aspirin, definitely. What was the other one? Acupuncture?
No, herbs.
Oh, herbs. Depends on what herbs. Nothing that I know of, but you can talk to Jennifer Strong, and she can definitely give you that kind of advice. And then acupuncture, somebody was asking about earlier on here too. Acupuncture may be helpful, and it certainly appears to be if it helps you stay calm and relax. So that might be a reasonable approach to things. Okay. Do you have more there?
I have one more.
Okay.
So
because there's a pile up here.
Do you think the individuals had another failed IUI and they're wondering if they'll ever have a baby?
They failed IUI and they're wondering if they're ever going to have a baby?
Yeah.
Yeah, I mean, there's loads of other options for treatment. There's different ways to do IUI. There are numbers of tries of IUI. There's IVF, there's surgery, there's donor egg, there's gestational carrier, there's donor sperm. I mean, we have loads and loads of options. It's very much dependent on how far you want to push it and what's right for you, and what's within your means, of course, as well. So there's lots of choices. There's lots of options. I'm never willing to give up until you are. So there are very, very few people who I will say, I cannot help you, or there are no options left for you. And, you know, in the end case, like where we can't biologically help you conceive, there is adoption, and we have patients that go on to that and do extremely well and are very, very happy parents. And, you know, it is one of the most noble things you can do. So there are lots and lots of options for you. I'm here to support you and help you. I won't give out or give up, sorry, unless you want me to. Any update on shipping embryos? Are they being monitored even if the clinic is closed? How do we know if they're safe? Kel, I don't know anything about Nahal, so I can't answer you. You'd have to contact them. I know some of the Nahal nurses are there, so maybe you guys can reach out, like they're watching. So maybe you guys can reach out or let Dr. Rathbauer know that patients want to know if their embryos are being monitored. That would be helpful. I finished my Provera to induce my period 7 days ago and nothing in sight. Last month, it only took 2 days. I did have a lot of changes in diet and increase in exercise. Could this have an effect? Do a pregnancy test. That's number one, and make sure that you're not pregnant. That would be the number one reason that the Provera wouldn't work. If not, come in and see us and we'll figure it out, and I'll be happy to help you out. Is IUI happening now? It will be very soon. So let Sarah know that you're interested and we will get back to you. What can be done to prevent miscarriages caused by PCOS? PCOS does not cause miscarriages as far as we know, although there's some evidence that it does. So again, weight management, if that's part of your PCO, is very, very critical. Vitamin D, inositol, NAC, those are all really important. A super healthy diet is very, very important. lifestyle changes. So 6 meals a day and exercise. So for PCO, I always approach it from 3 different elements. I always say there's a medical part, so that's letrozole and metformin. There's a natural component, so that's NAC and inositol, and NAC stands for N-acetylcysteine. And then there's the lifestyle component, which is weight loss through a healthy diet, including 6 meals a day, breakfast snack, lunch snack, dinner snack, and doing exercise. And walking is not exercise. Chasing other kids around is not exercise. We're talking about actual muscle building exercise. So HIIT training, high intensity interval training, weightlifting, that kind of thing. Anything like that will definitely help you quite a bit. Okay, we're winding down. When embryos are transferred to your clinic, will the storage fees be similar to Nahal? They're exactly the same. I don't want you guys having to pay anymore. When is the government funding coming to your Windsor clinic? For IUI, it's here already. For IVF, right to your MPPs, right to the government, right to the Minister of Health, scream, yell, send violent videos, whatever you can. Explain to them that we deserve it just like everybody else does. I don't know what else to do, guys. Hi, Dr. Victory. Would gluten-free diet really help with unexplained infertility? There are some people that believe that a gluten sensitivity can impact your fertility. And in fact, there's one study that says that it can. So if you are gluten sensitive, for sure you need to be off of gluten. If you are not gluten sensitive, it may help. I usually leave that one for the naturopaths to tackle, but there is some evidence that it can be helpful. Is it going to make or break your fertility? No. But can it be helpful? Yes, because a lot of people believe that gluten increases your inflammation, and inflammation is never good. Nick, what kind of precautions have I been taking for COVID-19? I have had more masks, which are here somewhere, than ever possible. So I've been wearing one of these N95 masks all day. I literally cannot touch my nose because I am so sore from bashing my face into that N95 mask all day long. We have Noveris air cleaners, which suck in every particle and molecule in the air and spit it out after it goes through this plasma coil. That kills everything. And between every patient, the room is wiped down with a CaviWipe, which is virucidal and bactericidal. So we've been doing everything we can. Thanks, Nick. Kiss the baby. Do I need a referral to make an appointment with you? My GP has moved and I don't have a new one at this time. Yes, if you're Canadian, we do need a referral, unless you're coming directly for IVF, in which case we can charge you, but I hate charging people. So if you can get a referral, even from a walk-in clinic, we are more than happy to see you, and then you don't have to pay. So just grab a referral from a walk-in. I am currently on a thyroid medication, levothyroxine. Can I still use my Pregvite vitamins together with this medication, or do I space them out? Ideally, you space them out. Because the vitamins can interfere with your thyroid medication absorption. So definitely try and space those out a bit. Usually they recommend at least an hour. If I ovulated on day 16, 17 and have very regular cycles at 28 days, is my luteal phase too short to conceive? No, Judy, that's probably very reasonable. A 12 or 13 day luteal phase is still a reasonable luteal phase. So even 11 or 12. It is a tiny bit short at 11, but 12 is probably fine. We will support you with progesterone, and that can help as well. So there are ways to make this better. Let's go back to Facebook. There's more questions. What's the earliest I can find out what the gender of my twins are? Also, is it more difficult to tell? It is more difficult to tell. Twin scans are really tough sometimes. Normally, we recommend around 17, 18 weeks at the earliest. There's a blood test you can do, but it won't tell you if, well, I'm not sure if that works for twins, actually. We'd have to ask. But there is a blood test you can do to determine sex determination. So that's a reasonable approach to things. What is the cost for tubal reversal and the success rate? So we charge about $6,000 for a tubal reversal. And the success rate is very, very high. We just had another pregnant patient from our tubal reversal. And she's actually pregnant with twins. I just scanned her the other day. Natural, but right after a tubal reversal. So yeah, we do very, very well. Usually it's up around 90%. Any idea when frozen embryos might be transferred? When the shipping company is willing to get in there, we're ready. So we've got the tanks. Our embryologist, Fariba Khoshravi, has gotten everything ready. She set up the lab beautifully. We are raring to go. So when I can get them in, I'll get them in. Do you recommend ovulation tests for PCO patients? Is it accurate? Not if you're not using something additional to help you with ovulation like letrozole and metformin. In particular, those tests look at your LH levels, and your LH levels are normally much higher when you have PCO. So those tests are not that accurate. You're better off coming to see us. We can do blood tests and ultrasounds and monitor you to see what's happening. But typically you need some help by using an extra medication and all those other things that we mentioned a few minutes ago to help you along the way. Every 2 days. Yes, every 2 days for sex. That's a good one. I had my first IUI planned and then COVID hit and it got canceled. What is the success rate on the first try? Thanks, doctor. Okay, so IUI just with your own natural egg is about 8%. IUI with a pill to help you, like Clomid or Letrozole, is usually around 10 to 15%. And IUI with shots is around 20 to 30%. Using this new Zymo technique and doing triggers can help even more, and that can be beneficial. Tarek, go one shelf lower. You want the stuff down there, buddy?
Yeah, I see it.
Yeah. Tarek's starving because it's Ramadan and he's been fasting all day. So big round of applause for making it to sundown, Tarek. I know that pain, brother. I get it. Jump into the chocolates there too. There's lots. We got more of those mint ones. Okay, is it normal to experience ovulation pain when ovulating? It's very normal to experience ovulation pain when ovulating. Will being on the thyroid medication affect my chances of getting pregnant? Well, not being on the thyroid medication will definitely impact your fertility. It is imperative that your TSH be less than 2.5, your T4 be in the normal range, and your antibodies be as low as they can possibly be. So all of those are really critical. Nick, I'm going to skip your progesterone question because we talked about it earlier. I have irregular cycles, hypothyroidism, and uterine fibroids. I am looking to change my prenatal Vite to something with inositol and Vitex. Is it okay to have it? Yeah, inositol and Vitex are harmless. I actually looked up Vitex. There's no proof that it works, but it's probably harmless. Inositol does have some evidence for helping. If you can find a prenatal with inositol and Vitex, which I'm not aware of, yeah, go for it. But the problem is irregular cycles are not okay. So you need medication if your cycles are irregular because that's an endometrial cancer risk. So it's important you take care of that. What are the risks of getting laparoscopy for endoadhesions before starting IVF? Oh, I get it. Okay. Risks. So every surgery, from brain surgery, which I've assisted with millions of times, all the way down to toenail removal, are the same 4 risks. So it's anesthetic, bleeding, infection, and injury. So there are standard risks across the board. With laparoscopy, in the hands of an expert, and I say that very strictly because not everybody is an expert laparoscopist, the risks are really, really, really minimal. You should have no complications, no side effects, no downtime, nothing. Well, some downtime to recover from the pain, but no significant side effects, complications, risks, anything like that. The worst we ever get is like a suture that's sticking out of the wound. Typically, most patients recover very quickly and very well, but it is imperative that you get a good surgeon. Do not just go to anybody. Make sure you have researched your surgeon. In particular, if you're in the US, do not go to anybody that is not AAGL trained. You want an AAGL trained, fellowship trained laparoscopic surgeon. The rest of them, I've heard nightmare stories, and quite frankly, I've seen them myself when I was there for 3 years. So you gotta be super cautious about that. Okay, I think I'm gonna take a last one. How early can a vaginal ultrasound detect a pregnancy, even if it's just seeing a sac? So around 5 weeks and 4 days or so, we'll start seeing a sac. 5 weeks and 2 days, we'll start seeing a sac sometimes. Fetal pole with a heartbeat at the earliest, 5 weeks, 5 days, 5 weeks, 6 days. So that's about the earliest you're going to see it. And what are the credentials? Okay, a couple more quick ones from Facebook. Do you need a prescription for Pregvite? Yes, you need a prescription for Pregvite. Just call the office. You don't have to come in for something like that. On top of the prenatal Centrum and extra vitamin D you prescribed me, should I be purchasing other specific vitamins, or does the prenatal cover all recommended doses? If you're taking extra D, the only extra thing that most prenatals don't have is the fish oils. So take an extra bottle of fish oils. That's all you need. And it's another question says, what are the credentials for hysterectomy? Nat, I don't know what you mean. But if you mean what are my credentials for hysterectomy, I did a 5-year residency in London, Ontario, and did tons of hysterectomies. I have taught other people how to do laparoscopic hysterectomies. I was hired by Johnson & Johnson to teach people how to use their Ethicon device, and so that works. The movie recording stopped spontaneously, it says. So yeah, there's all sorts of different things that I have, and then I did a 3-year fellowship in the US where we did more laparoscopy, and I was trained by one of the greats, Dr. George Vilos. The guy is amazing. He can do things in his sleep that the rest of us can't do after years of training. So, okay, I got to wind this down to get home to the fam. So, cycle day 60 of a letrozole cycle. Wow, you need to get your hormones checked. So if you're cycle day 60 of letrozole and you took Provera a week ago and you have not had a period, something is definitely not right. Make sure you've done your preg test and go from there. That would be really, really important. I see a few folks that have just joined us. I'm actually signing off. So Suzrad3 and Apes Crowder. I'm sorry, we're signing off now, guys. You jumped on a little bit late. You can watch all of our shows, and all of our shows are available on our YouTube channel. This will be replaying immediately on Instagram. Does it replay on Facebook for the first 24 hours too?
Well, it stays there.
It stays on Facebook. Okay, so it stays on Facebook. It stays on Victory Reproductive Care YouTube, and it stays on Instagram for 24 hours.
It's best on YouTube.
Is it best on YouTube? Tarek says it's best on YouTube.
It's got the stamp, man.
There you go. It's got the stamp. That's right. And our little sperm animation.
Yeah, that's right.
So thanks again for joining us, guys. I want to know if there are topics you guys want me to look into. So don't hesitate. Like, send us a message. DM me on Instagram. Tell me what you want me to talk about next time. If there's something that's of particular interest to you, I will discuss it. And we will go over it, and that way we can get something that everybody's interested in. We're also going to start a Facebook group very soon, invitation kind of thing, where you got to answer some questions to get in, and then we can have discussions there as well and go over things as a group. And hopefully we can build that up into something really unique and special for lots of people to enjoy and benefit from. So thanks again for joining us with Fertility Fact or Fiction. Love doing this. Thank God we're all looking forward to the fact that COVID seems to be dwindling, although it has not gone away. So still practice your social distancing and all of the healthy new habits that we've all learned. Clean everything, avoid close contact, and don't go jumping into group activities yet. We're not quite there yet, guys. I saw a whole bunch of people walking together on my way here today. I don't think we're there yet, so still be cautious. There's still lots of work to be done. Have a good night, and we will chat again